Thank you once again for coming together for this session. I have to say that I admit that I am a bit of a nerd, but I have to say that these last two panels left me very excited. I have to congratulate the Unite team and all of our collaborating partners of bringing such interesting people with such diverse experiences, with such inspiring stories, to share them with all of us. And I think that we are all leaving this room at the end of the day with stronger confidence in everything we are defending, hopefully learning new lessons and moving forward. The Unite team has asked me to very briefly sum up some key ideas from today. And I would say that from the first panel, the message is clear. Decriminalization works. Portugal showed its example 20 years later. It's 20 years ongoing. Many times I go to many places in the world where people say that the Portugal experiment is interesting. And what I have to say now is 20 years later, it's not an experiment anymore. It's concrete, it's real, and it has had impact on people's lives. And I think this is extremely important. And as we heard on and on again, it is not the full solution, but it is a needed part of the whole solution if we want to have a true public health, person-centered approach. And we heard then the need for the different parts of that puzzle to work as prison health, as we heard from Guilherme Macedo on the need, as he mentioned, to go there and solve it out of the hospital setting. João Golão, of course, shared his personal experience, and Luís Mendão went even further, calling on the need to not forget the approach to the vulnerable populations, and calling on civil disobedience when needed. I'm not going to endorse that, but I think it is effective in some situations. Then on the second panel, where we heard about the global picture of opportunities and lessons to scale up on harm reduction, I mean, if there were doubts about the importance of opioid substitution programs, what we heard from the rollout of methadone in China with an HIV incidence decline of 96% is tremendous. And I think we should look at this and understand that there is nothing more powerful when it comes to policy than showing concrete data and evidence. And Maria Goretti showed us many of the challenges we are facing, especially in Western Africa, and a very clear message that she shared with us that there is lack of understanding about harm reduction. We need to do more work, we have to do better work, and that punishing drug use clearly does not work. And she showed that we are still very far behind when it comes to examples of OST and NSP across the region. Dr. Fadi showed his experience in the Montpellier prison. I remember from our previous policy day where a very important quote came out that said that prison health is public health. And I think that applies very clearly to his presentation of how we need to be effective in prisons where people are incarcerated. It's an opportunity that we cannot lose, but we also need to endorse ensuring health and social responses when people leave prison. I think that was a very powerful message also. And not to forget, once again, not to forget the invisible. And Leon Garcia in that sequence showed how deaths among the drug users, 6 out of 10 is due to homicide in Brazil, 1 out of 10 due to overdose. So there is tremendous stigma and discrimination. There is a need to deal with the social determinants and the end of what he called the meritocracy of care. People should not have to deserve care to get access to care, and I think that's very, very powerful. And the need also, now that there's a presidential decree moving away from harm reduction, for policymakers in Brazil, in the region, to continue to endorse this evidence-based, cost-effective approach. And that led to fair and justice prosecution with Miriam Krinsky sharing this vision. Coming from the US, many times not prone to moving away from a criminal justice approach, showing that there is a new generation of prosecutors, of justice leaders, opening the way to a situation where hopefully many of the challenges we are facing can be overcome despite the law, showing that prosecutors are the gatekeepers and that they can have an action in making sure that people's life cycle does not have to be destroyed through unjust criminal action. And then we heard Naomi Berkshire from HRI, and I have to thank Naomi personally because, of course, this session would also not be possible without Harm Reduction International. And the people at Unite, mainly Christina Amish, know when I met Naomi in Bucharest a few months ago, and as soon as I landed in Lisbon, I gave Christina the card, Naomi's card, and I said, leave whatever you're doing and call Naomi, we need to follow up. And the proof that it was worth it is here today. It was clear that we needed to join forces, bringing together our policy views, our policy action, our members of parliament, hopefully to be able to push the agenda forward along with the power of the Harm Reduction International Conference and network. And so it is clear, I think, as a main conclusion that, of course, harm reduction works, harm reduction is cost effective, and it is based on evidence. We need a whole person approach, and we need political leadership. And when it comes to HIV, HCV, TB, we need to have a holistic approach. We need to deal with the person as a whole. We need to look at the cascade as a whole, going from awareness to prevention to diagnosis to testing and diagnosis to access to care and treatment. We need a human rights approach. And when it comes to harm reduction, Alexis said it is by nature unconditional. And so I would end by saying harm reduction and love share a common denominator. For it to truly work, it needs to be unconditional. Thank you. And having said that, I have to apologize on the behalf of the Honourable Member of Parliament, Moisés Ferreira from Portugal. He is not going to be able to join us due to health issues within of a family member, and he has asked me to apologize on his behalf. However, before passing the floor to my honourable colleagues and members of Parliament, I would just like to, in 30 seconds, say that the reason why we invited Moisés Ferreira, who is a member of Parliament, is very clear and related to harm reduction. Just to be clear, I am a social democrat, and Moisés Ferreira is from a party called the Left Bloc. We are very distant from one each other ideologically. And we sit across the table in the Health Committee, and we disagree on a lot of things. People in Portugal know this and see this on a daily basis. However, there are some issues we are able to go across the aisle. And I have to say this, I've never said this publicly. I hope I don't get whipped after. But I think it's important because of the power of Unite. I believed that as anyone in this room, that we need universal coverage and funding of harm reduction services, potentially by our health system. And the truth is, in my party, I was unable to convince them that we needed to move from the situation we were before, from 80% funding towards 100% funding. Because many NGOs in our country, community-based organizations, needed to fundraise the additional 20%. And if they were unable to fundraise that 20%, they would have to close down that harm reduction service. If we acknowledge harm reduction as an important part of the full puzzle of decriminalization, of the public health approach, well, then we need to fund it 100%. And since I was unable to convince my colleagues, I wasn't persuasive enough in my party, we had a very long discussion in the parliament, and I spoke with Moisés, and he offered to step forward during the budget discussion, and his party presented the proposal to make harm reduction funded 100%. After the proposal was out there, a discussion began, and it was an ongoing discussion for a full month. And within my party, I had an opportunity during a whole month to show them the importance, the evidence around harm reduction, and actually how very low cost worthy it was in comparison with the rest of the health budget, especially how much we had to gain through the outcomes that could come out of the effectiveness of harm reduction. And my party then turned around and gave authorization so that we could vote in favor. And despite not having the vote from all parties, my party, in this unusual coalition with the left bloc, came together and we voted. And in the last state budget, 2019, it was voted in November, we passed the law that made harm reduction 100% funded by the state. And I think that's a powerful story. And although Moises is not here, I wanted to publicly acknowledge his leadership and his understanding of the issue. And I think that goes to show when the power of evidence and science is there are ways to overcome the ideological barriers that sometimes stand between us. And that being said, it is my great honor to start by presenting the honorable member from Parliament from Kenya, a dear friend who has also been with us in the previous policy day. So she's already a Unite veteran, the Honorable Esther Pazaris. The floor is yours. Thank you.
Good afternoon. I'm a social entrepreneur, a businesswoman. I believe that when you do business, you have to do something good to the society. So my first business was employing deaf people. My second business was working with street families. Most of them were drug addicts. And there was no harm reduction program. I just said to them that if you're going to work for me, you're going to try and not have your drug until the evening, so at least you can cover the working hours. And they were really good. Majority of them actually shaped up. This was glue sniffers, not really injectable drugs. And I saw that when you give them an opportunity to earn an income, they can clean up, they can take a bath and wear good clothes, they can be proud of owning a bicycle, they can be proud of coming to work and getting their salary as opposed to being on the streets. The project was called Adopt a Light. I got the UN Habitat Award because of it, and many other commendations from Kenya. The reason I ended up being a member of parliament was not by design. I didn't think ever that I'd be a member of parliament. And when the project was fought by the government, I decided I'm going to run for an elective position. And I ended up in parliament. And at that time, there were mothers that were being detained in hospital because they couldn't pay their hospital bills. So when I got into parliament and I was asked what committees you want to get into, health committee was one of them. And I came to Portugal with the health committee last year and got to understand about the harm reduction program. Just before I came here, as I got this invitation from Unite, and I really want to thank Ricardo and his team for what they're doing, and everybody that's sitting here. I mean, I always say that we're working not for ourselves, we're working for people. We're trying to restore humanity. We're trying to bring humane ways of dealing with people. I once went to visit patients in Kenyatta National Hospital after the post-election violence, and I found a few of them handcuffed to the bed and in agony, and I thought, what's going on here? And these were criminals, and I thought, wow, but even when they're here, we have to handcuff them. There is a way that we do things that is not humane, and I think as we get highly populated, we kind of reach a point where we just think about what we have to do and how we have to get through the day. While I'm in parliament, I'm thinking, what are the laws I have to pass, or what are the areas? But I'm a member of parliament for Nairobi County. It's one of the biggest counties, and it has 17 constituencies, 85 wards, and a budget of $1 million a year to basically uplift everyone from poverty. And a week before I came here, I went and decided to visit all the harm reduction centers, and I can say I'm proud of Kenya and where we are at the moment, but I'm absolutely petrified on if donor funding is withdrawn. We really need to fight for Global Fund to get to 18 billion as wanted, because if we don't, then countries like Kenya will not be able to sustain the programs that they've already gotten into, like the harm reduction. I met the young men and women there, and they actually are so proud of their achievements, but they have to walk a long distance. So we need to find a way to give them transport or to get the mobile clinics going round. We also need to give them livelihoods. I met a young man who's so proud of his recovery. He sleeps on the streets next door to the center, and he said to me, he says, I want to be a driver. And I looked at him and I thought, wow, he could make a driver. But then there's a high rate of unemployment. And they all, almost 90% of them, have got criminal records. And how do you get people to agree to employ somebody who's got a criminal record when you've got people that are unemployed without a criminal record? So I think we have to involve the private sector, but more than that, we have to tap into entrepreneurship. So, you know, from my fund, we're going to try and make sure that we create we put them together. We create laundries, we create bakeries, so that they can basically be self-employed. So for me, the harm reduction program is humanity restored. It's caring for the one that got there. And when I asked most of them, how did you get here? Most of them said peer pressure, hopelessness, unemployment. Families don't want them back, but there is hope in that 40% of them have been integrated. Some of them have returned back to their families, continued, picked up. It's a tough life. It's not easy. But I believe that we need budgets. We need to sustain what is already there. We can't, and expand it in terms of mobile clinics. So everybody that's sitting in this room, harm reduction is something that we can't let go of. We have to try as much as possible to ensure that it is sustained. Leave no one behind. That's an SDG motto, and I really believe that as a Member of Parliament, that's what I will do, and that's what I'll advocate for. Thank you very much.
Thank you, Esther, and for being on time also. And Esther also has some slides showing some of the work you've been doing back home, and we'll be able to share it with the participants, of course. Now it's my honor to present the Honorable Member of Parliament from Indonesia, the Honorable Nova Yusuf. The floor is yours. Thank you.
Hi, I'm very sorry if I look sleepy. I just realized this is midnight in Indonesia. So thank you for the organizers to give me the opportunity. Obviously, I'm not a veteran on this issue because I've been working closely with mental health issue in Indonesia. When I left for Portugal the day before yesterday, we still have 2 presidents in Indonesia because we just had an election and the result is yet to come. And it is very important to know the result that was going to be the president because it will decide the future of the harm reduction program in Indonesia. Yeah, so this is exactly, not exactly my first visit to Portugal. This is the second visit. In 2012, we went here with stakeholders and we visited the Dissuasion Commission, we went to the Parliament, we went to the Ministry of Health, we went to prison, and of course we went to Santini ice cream. Yeah, so there's a lot to say. Indonesia is the 4th most populous country in the world, of course. Some of you may have known. We have 16,000 more so islands, so you can imagine it's the gateway for narcotics to enter our country. And we have quite an immense number of drug users, 3.4 million, because we have 264 million people in Indonesia. And estimated number of people with HIV/AIDS is 640,000. So it's a challenge. The harm reduction program in Indonesia is somewhat rely largely on the amount of money from international funding, which at times is problematic. I was trying to, when I was becoming member of parliament, my idea was to pass the mental health bill into law, so I did. And one of the articles that I tried to fight was to include a 10% provision of bed and facilities in mental hospital, so we can have more rehabilitation facilities for narcotics users. But unfortunately, it's not yet to be implemented after 5 years, while I actually plunge into the fountain in the parliament when I was so happy the bill was passed into law, and no, it's not being implemented up till now, but I'm okay. Not really. But okay. About the budget, somebody talked about the money from MSF. We have problem actually. Indonesia has the universal health coverage program since 2014. So the target is for universal coverage in 2019, which is this year. Unfortunately, there has been a stigma. It's not exactly a stigma, but the director and the board of directors, and they consider that drug issues or drug abusers are an act of self-harm. So instead of being funded, they deny of coverage. Other than drug abusers, also suicide is denied of coverage in our national health insurance system in Indonesia. We're already on the right track, but still we need to change the mindset. The main focus of the harm reduction program is the distribution of clean needles, of course, but still it's also stigmatized. And another program is Indonesia's condom campaign to fight for AIDS, was also criticized by religious groups in 2012, so it had to be put on hold. But it doesn't mean that Indonesia does not have roadmap. We do have roadmap, which is we have target for the elimination of HIV/AIDS in 2030. So there has been a fast track started in 2018, and hopefully it will be achieved in 2027. There's been an interesting reflection about the implementation of harm reduction in Indonesia. So it is said that it's more, to switch their addiction from illegal to legal substances, and that it's not improving the quality of lives of the users. So it instead continuously reproduces the precariousness of drug users' life. So this is a research that I read from an Indonesian PhD scholar in Northwestern State University. So, and thank you for the opportunity, because this morning I get to see Norte FIDA, and I'm convinced that we need to have independent budget allocation. It's hard for us to continuously expect from the funding from like Global Fund or something like that, because we need to. The only entry point for Indonesia for the operational of the harm reduction program is through compulsory report program, which is not very successful in Indonesia, not yet. And we have been very supportive since 2011, but unfortunately the target cannot be met. So we funded quite a lot of money for compulsory report, but a lot of the users are afraid that they're going to be criminalized. So it is a problem. But learning from Portugal's drug decriminalization, we are hopeful that Indonesia will be able to reform or to revise our narcotics law, because we already had that, but it's very important to revise. And we are also learning from Portugal that we need to incorporate the research, evidence-based advocacy of human rights, and also the need to understand about best practices, and of course to be actively involved in this activity, in this forum. So that's why I am here today in this international meeting to unite. Thank you.
Thank you so much, and for that Unite reference at the end. We appreciate the publicity. And now it is my honor also to call the honorable member from Ukraine, Serhiy Kyral. Forgive me for the pronunciation. It's my honor to present you, and the floor is yours.
Thank you. Well, thank you very much, Ricardo, and thank you for also extending the invitation to me to participate in this very important event. I'm new to the subject. I'm new to politics as well. And if you look at Ukraine, Ukraine is one of the countries of the post-Soviet bloc, or one of the colonies of the Soviet Russian Empire, which is now going through difficult times, as you all know, transitionary times. So we have to deal with a whole myriad of different challenges and issues at the same time. And there is also so much capacity and resources they have. So If you look at the policymakers, it's also very important to look at the environment they're working with, and how this environment also what kind of impact it has on the priorities are being set. You probably all know that Ukraine is also a victim of the aggression of the neighbor state of Russian Federation. 7% of our territories is being now occupied and Crimea annexed. It does poses also a number of public health issues. These occupied territories are not really being controlled by Ukraine, effectively by Russia, but not by Ukraine. And before the occupation, those were the territories where we were seeing quite significant, the highest numbers on average as far as the TB and other infectious diseases are concerned. So I'm really grateful for the Global Fund present here, who has had some creative approaches to propose certain programs. And there are some NGOs who are shipping medication, and some people who are there still trying to help and trying to provide services to the patients. Overall, Ukraine has nothing to boast really on the positive side. We do admit we have an epidemic as far as TB and HIV is concerned. We have around 23,000 cases of new cases of TB being registered on annual basis. About 4,000 people dying. So basically every day we have 10 people dead from TB. We have more than 240,000 people living with HIV. And there is the most vulnerable groups are, of course, the people, the injective drug users. We have 350,000 of the injective drug users. 22% of them are with HIV and MSM. And these are the just of the few challenges that are there. It is not the problem with the funding or the money, though, and the infrastructure. The post-Soviet infrastructure of the hospitals and the available personnel is there, and the Global Fund is still very active in Ukraine. So the problem is probably somewhere else, and the problem is in the attitudes and the approaches, which need to be changed. These new changes, new policies, probably require also new people there, and this is people like myself, the people of the new generation of politicians that can contribute, I believe, a lot. It will take a lot of learning also from us, and that's why different networks of the parliamentarians like Unite, but also the Global TB Caucus, where I am a member of, and also a regional co-chair for Eastern Europe and Central Asia, that give a good backing in terms of expertise and networking and communication for us to be able to bring this knowledge and expertise to our home countries. In Ukraine, it led to me also to create an all-party parliamentary group in the parliament. We call it a parliamentary platform to end TB, where we have managed actually to become a ground of networking and putting together all the stakeholders, including the ministry, the civil society, the different international donors, where they can come together without any politics involved and discuss issues. The new 5-year state program is being now presented for the parliament in being debated. And of course, I was personally also very much active in preparing to the high-level meeting of the United Nations, being a member of the Council of Europe Parliamentary Assembly, a rapporteur on tuberculosis, contributing and representing the Council of Europe also in New York, meeting a lot of people, also some of them present here, which is another objective for our parliamentary platform right now, is to keep the government accountable on the political declaration and some of the objectives and goals set for the Ukraine and the countries in the region. So I am a believer, a strong believer of the parliamentary networks and the parliamentary level as an important criteria and important element of the policy changes in any country, not only the countries in transition like Ukraine. So I look forward to having more contacts, and have already met a number of people and continue to talk to you during the dinner today, and bring back for sure many ideas that we have generated here. Thank you very much.
Thank you, sir. And your belief in parliamentary networks is something I think we all believe. And on that premise, I would also like to acknowledge the presence of our honorable colleagues from 15 different countries. We didn't have time or room to put everyone speaking in the session today, but there are many parliamentarians, honorable representatives sitting in the room today, and I would like to thank each and every one of you for finding the time to fly to Porto. You've been sitting here all day, which shows your willingness to learn and to share experiences and to hear the evidence around drug policy, infectious diseases, and of course harm reduction. And I'm sure you make your citizens proud with this willingness to learn more, because at the end of the day what you want to do is to deliver better health for all back home. And this being said, we have time for one round of questions for the honorable members of parliament before we move to the next part of the session. Is there any question in the room?
My name is Céline. I work for the medical international organization Médecins du Monde. I would like to ask you what concrete action you as a member of parliament can do to engage your peer parliamentarians to understand more about harm reduction and drug policy, because we know, and it has been said, that there are so many misconceptions and people thinking to drug issues and drug policy in a very oriented way that is not always evidence-based. So my question is, how can you engage your peers parliamentarians?
Thank you, Celine. I'll give each of you in the same order an opportunity to respond briefly.
I mean, how can we engage parliamentarians? I mean, first of all, I think we have to have a strong civil society, because parliamentarians normally are driven by civil society. I mean, in Kenya, we've seen a lot of people from civil society move into parliament. Now we need to ensure that the existing civil society are able to engage us and then lobby us. But I think the most important thing is to also make parliamentarians understand what's going on. So for me, as an elected leader, I'm actually going to try and get a few of the parliamentarians that I have to actually go out with me and see what's going on, so that they can be convinced that this is a good program, especially the budget committee, because they're the ones who control the money. But the other thing is to ensure that we celebrate our partners. I mean, I think the Global Fund is doing a lot for Kenya, and we can't afford to lose them, especially now when Kenya is really high in debt and has very little resources to probably continue some of the programs that they're doing. But it's lobbying, it's a continuous process. But I think if you get them into the emotive issues, if you get them to be involved, like actually go out and see, I think every parliamentarian would want to address it, especially when we talk about the fact that harm reduction also reduces crime, and we all want crime to be reduced.
Thank you, Esther. Nova?
Yes, thank you for the question. So there was my experience during my first period in the parliament, which was in 2009 and 2014. I was in the Health Commission, Health and Manpower Commission. So I had, unfortunately, the counterpart for the National Anti-Narcotics Agency is Commission 3, which is more of the justice criminal system there. So I try to bridge between commission. So that's why, for one example, is the compulsory report funding. The budget allocation is somewhat scattered in different ministries, in the Ministry of Social Affairs and National Anti-Narcotics Agency, and also in the Ministry of Health. So I have to do my part. I had to do my part in my commission. So I had to ensure that the budget allocation was somewhat as proposed by the Ministry of Health, but unfortunately in 2012 they were unable to utilize the money. So I was very sad because we have pushed so hard to endorse the financing. And secondly, we need to, I bridge with the Commission 3, which is responsible for the laws, for the criminal and justice system. So, but it was the most difficult part because we need to synchronize between the mindset itself of decriminalization and also the fact that when we did some working visits, we realized that usually when they're being, the decision in court was never to benefit the users or the drug abusers. So instead of getting rehabilitation, they usually end up in prison and after custody. So it's really difficult because the law, we need to revise the law. So that will be, I will pass the torch to the next generation because I will step down from the parliament. So I've done my part, by passing the mental health law and also doing the this. I think it's very important to revise the law, the existing one, because it's still ambiguous, it's still confusing, it's still so easily corrupted by the either police officers or other criminal justice system in Indonesia. So yeah, I think that's what's been done and what will be done. And also in the mental health law, we incorporate the rehabilitation program to be, to destigmatize both mental illness and drug abuse. So that's why we say, okay, we should give 10% of mental hospitals to rehabilitation program. So that's what I say. It's so sad. It's not yet being implemented up till now. So yeah.
Thank you. No, sorry.
Thank you. Well, on my side, from my personal experience, I think it's very important when there is an area of different international networks which pay attention, which are active on the national level, including. So they can be international, multinational, or supranational, like the Council of Europe, for example, the International Parliamentary Union, but also the networks like UNITE and the Global TB Caucus. That gives a kind of a halo around the issue and attracts the attention of the parliamentarians. This is something that we need to look into because the international community needs that. In Ukraine, in our case, it works a lot. For example, if you take our reforms agenda and sector by sector, you see there's a lot of engagement from the European Union, from the IMF, from the World Bank, from the WHO. And that increases the visibility and it makes the parliamentarians, the policymakers, have a feeling of being engaged with something very important, even if they're not experts in the field, even if they do not have any emotional or personal experience with it. It gets them driven, gives them motivation, gets them involved. The other instrument I find quite effective is by creating these all-party parliamentary groups, which you can use also as a counterpart for the civil society. And in my particular case, I'm really grateful to have strong counterparts in the form of the Alliance of Public Health, who is the counterpart in turn to the WHO and the Global Fund and many other donors who are working as a helping hand, or basically the working hands for me and helping me to produce the evidence, to organize the events, roundtable discussion, exchanges, different visits, produce reports also. In March, we have marked the International TB Day, where we had also constructed this symbolic clock in front of the parliament and hold a press event with the Minister of Healthcare. So these kind of things would just be impossible to do without the strong backing from the civil society. And that is, I think, the success factor, another critical issue for the parliamentarians' involvement. Thank you.
Thank you. And I think what is very clear from all of your three views in response to how to engage parliamentarians is that parliamentarians, as any other citizen, needs a human-centered approach, and the sense that there is a need to tailor actions to parliamentarians and to each country's needs and each region's specificities. And this means that at Unite we end up dealing with this from a multidisciplinary approach, is understanding what strategy works best. There are some common strategies no matter where we go in the world that always work, which is ensuring face-to-face human interaction among parliamentarians to share those examples. The field visits, as we've done this morning, to understand the real-world context of what we are talking about, and then on theoretical terms in conferences. But then there is a need within what we call the magic diamond of the 4 pillars that can provoke policy change, which is the scientific community, which includes, of course, the healthcare practitioners, the media, civil society, and politicians, understanding which parts are missing. In some countries, we need to have a stronger civil society, as was mentioned. In others, media is against it, and we need to convince media and raise awareness of the general population. In others, we need to make sure that science, evidence, healthcare professionals are more active. And in other situations, you actually have the 3 of those, but you don't have the parliamentarians or the policymakers or the politicians. And it's working with these different variables and adjusting the strategies with multidisciplinary approaches that we can truly unite for that change. And that's how I gracefully included Unite there. And now, to continue the discussion, I will call in to the stage, asking my honorable colleagues to stay, if you don't mind. There might be more questions. I would call to the stage the 3 next speakers, please. Craig McClure, Senior Director at the Clinton Health Access Initiative. Lucy Stackpole-Moore, Director of HIV Programs and Advocacy at International AIDS Society. And Marieke Wiedenroks, Chief of Staff of the Division of Tuberculosis and Malaria at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. Thank you and welcome to the 3 of you. And without further ado, to make sure we're able to keep on time, it is my honor to present Craig McClure from the Clinton Health Access Initiative. If you want, you can speak from the chair, or if you want to go to the podium. The floor is yours. Thank you.
Thank you very much. Thank you for inviting me. Just for people who don't know who CHAI is, we were set up in 2002 essentially to support the emergency response to HIV and AIDS around really 2 areas: working to market shape to reduce the price of drugs and diagnostics, and to support governments directly behind the scenes around the establishment of national programs for HIV, things like costing, planning, monitoring and evaluation tools, and training of healthcare providers. In the last few years, CHAI has expanded in the areas that it works, and 4 years ago prioritized work in viral hepatitis. And I recently became the director of the viral hepatitis program at CHAI, having worked in HIV for 25 years. And the reasons that I joined CHAI are the same reasons that CHAI's prioritized viral hepatitis. Number 1, the disease burden. Dr. Tato Mourinho pointed out some of the statistics, but 350 million people with hepatitis B and hepatitis C. And the IHME last year in the Global Burden of Disease report predicted that by 2040, deaths due to viral hepatitis, to hepatitis B and hepatitis C, will outnumber the combined deaths of AIDS, tuberculosis, and malaria. And today, deaths due to viral hepatitis are around the same as AIDS, TB, and malaria separately. Also that viral hepatitis causes the vast majority of cancer, of liver cancer. That was also outlined earlier today. And the vast majority of liver disease, liver cirrhosis, is caused by viral hepatitis. But we chose hepatitis C to focus on for 2 main reasons. Number 1, what was called the miracle drugs, the direct-acting antivirals that became available in 2014. Drugs that work across the genotypes of hepatitis C, Because of that, because of those drugs, it means that we could work to simpler public health approaches to treating and curing hepatitis C. These drugs cure hepatitis C in 12 weeks for patients without liver disease, 24 weeks in patients with more advanced disease. They have virtually no side effects, as was outlined. The adherence issues are not complicated. So it meant that you could deliver hepatitis C treatment and cure at lower levels of health facilities. You could integrate with other services, you could decentralize, and you could task shift from hepatologists to GPs to nurses and ultimately to community health workers. But the second reason we focused on hepatitis C was because there's significant market shaping opportunities to reduce the price of DAAs and the price of the viral load tests that are required to do them. So we're now supporting 7 countries, 2 in Africa, Rwanda with a hep C prevalence of 5%, Nigeria in the state of Nasarawa with 10% hepatitis C prevalence, and in Asia, Cambodia, India, Indonesia, Myanmar, and Vietnam. And of course, we'd like to support many more, but the fact of the matter is that the opportunities, the funding opportunities, are really not there from the major donors around the world. Now, I just have 3 brief messages, key messages for the decision makers that are in this room and that are listening out there, whether it be parliamentarians, people making policy decisions, or funders. The first key message is that the price of the commodities, at least for the 100+ low and middle income countries who have access to licensed generics, is really no longer the barrier. The DAA drugs that 5 years ago when they were introduced cost $100,000 per person, $100,000. The global access price the next year in 2015 from the originators was around $800 or $900 for low and middle income countries. Last year, the Global Fund reference pricing for the DAAs for pre-qualified generic medicines was $102. And just a couple of months ago, in Rwanda, the Rwandan government, with our support, was able to secure a price of $60 per patient cured. So that is really no longer a barrier anymore. Similarly, viral load prices are coming down dramatically. In Rwanda, who've committed to eliminating hepatitis C in 4 years from now, 5 years from last year, for a total price of less than $100, a person will be able to be cured. The drugs, 2 viral load tests, and a rapid screening test. The second message of the 3 is that the world cannot eliminate hepatitis C without eliminating it in people who inject drugs. About 8% globally of people with hepatitis C are people who inject drugs, but much higher in many countries. And of new hepatitis C infections, the vast majority of them around the world are in people who inject drugs. The third and final message is that the screening, diagnosis, and treatment and cure of hepatitis C among people who inject drugs is a major opportunity to expand harm reduction interventions, needle and syringe programs, opioid substitution therapy, particularly if it's done in a patient-centered, community-based way. HIV prevention outcomes can be enhanced through treatment and cure of hepatitis C, and HIV care outcomes for people who inject drugs and are living with HIV on ART can be enhanced through elimination of hepatitis C, cure of hepatitis C. So I'll stop there, but just to say, I think the world has an opportunity now to eliminate hepatitis C, to eliminate it among people who inject drugs, and to use that opportunity of curing hepatitis C among people who inject drugs to enhance our overall harm reduction interventions.
Thank you so much for that powerful message. Very clear, and this need on finding those missing millions out there through testing and ensuring access to treatment. I think it's very clear that elimination is possible. Thank you. Now, Lucy Steckwell-Moore from International AIDS Society, please.
Thank you, Ricardo. I did have a very short presentation, if that clicker...
Please.
Oh, I was going to get too lazy and sit in the chair. Is the clicker here? Ah, yeah. Great. So thank you very much. I think I'd firstly like to congratulate Ricardo and Unite and all of the organisers for a really terrific event this afternoon. And it's a real honour for the IES to be sharing this platform with such a distinguished set of speakers and some remarkable examples from political leadership and also great science and documentation that we've heard in the previous sessions from around the world. So thank you very much for including us and congratulations for the day. I think from the perspective of the IAS, we fully acknowledge the great power of convening such conversations to bring together expertise, scientists, political leaders, community activists, people living with and affected by different diseases. And I know we're about on the doorstep of another great conference on harm reduction, and certainly for the IAS we really acknowledge the great power of convening such important conversations to help keep everyone on the pulse, I think, in moving concrete actions and positive change forward. I'm not going to say too much because I think a lot of what I was going to say here in terms of scaling up access to harm reduction has been covered. So it's given me the opportunity to go into a little bit more depth, I think, but I'll be brief. Just to introduce the IS and what our role is in this space, we have an initiative that really focuses on HIV co-infections and comorbidities, including viral hepatitis, also tuberculosis. And the specific sort of framework for that is that we're always evidence-informed and human rights-based, and that's a theme that's really come out often in many of the speakers today, and really we've heard about the power of evidence and science. I'm going to come back to a key take-home there that I want to challenge us all to go a little bit deeper in terms of what we mean by evidence-informed. But in terms of our specific initiative, we've really focused on the rights and barriers and opportunities to better meet the needs for people who inject drugs from the perspective of co-infections and a holistic approach to their health and other social needs. We have a specific policy brief series. There's 2 out the front for you to please take away. Take as many as you like, that we've published last year and just now this year. The first one is called Ending an Epidemic, very much focusing on prioritising people who inject drugs in viral hepatitis elimination efforts. And the second one, just released on International Women's Day this year, was specifically looking at women who inject drugs. And I wanted to just also thank our supporters of this, as NIDA and OSF, because actually that's enabled us to publish these not only in English but also translate them into Russian, Spanish, and the most recent one into Portuguese as well. And I think we started today with the importance of language in terms of sensitive language. I think I'd also like, and the IS, we need to be better at this also in translating into languages other than English as well, so that it can reach more people around the world to share good practice and the latest science. And we have a couple of other policy briefs in development, specifically looking at different populations, young people who inject drugs, migrants who inject drugs, some of the nuances around integration and community-based service delivery to meet the needs of people who inject drugs, law enforcement and harm reduction, and the role of police and legal policies, if that makes sense, and the framework, and also specifically on overdose treatment access and some of the nuanced issues there as well. So watch this space for those policy briefs coming out in the next few months. So to respond to the focus of this session in terms of scaling up harm reduction, I think from my side there's 3 messages, and it's really on the service level, looking at how we can best share bidirectionally from HIV towards viral hepatitis and vice versa in terms of best practice. What works, what models of integration works, and really how does it best meet the holistic service needs of the individual people there. And I think in terms of being evidence informed, there's a real need to make sure we're disaggregated in the kind of evidence we're talking about. And the latest policy brief about the needs of women who inject drugs really makes that point very clearly. But also thinking about young people and age disaggregation. Are we collecting the kind of data that we need to best inform if and how we're reaching the needs of young people, women, also people in different cities or in rural areas? Do we have fit-for-purpose data processes, public health surveillance, monitoring and evaluation of projects to know if and how we're best reaching those different groups within specific key populations? The second one is really looking then at policies and the political will, and it's not preaching to the converted, but we have a lot of very visionary political leaders and policy leaders in this room. So congratulations to everyone who is that, because it's people like you who are inspiring others to have the courage, I guess, to maybe talk out about unpopular issues or to spotlight or have those difficult cross-party conversations to really galvanise political momentum, not only for policies to change, but also for due investment to make sure that those policies can be implemented and have a positive impact. And the last one I wanted to talk about was then the issue around stigma, many people have mentioned that as well, and I think it's something for all of us that we can do more to have the courage and the confidence to speak out and address stigma when we see it, when we recognise it in ourselves. It's a very human thing to do. It's very much linked to our own values and attitudes, and to really have that courage to acknowledge that, speak out and confront stigma for ourselves, for our partners, our families, our constituents, and really to have those difficult conversations and do something concrete to get to the heart of stigma. That's a campaign we're developing this year, but it's really that soft stuff, that emotive stuff that's here. It doesn't sit here in terms of the science and the knowledge and the best practice. It's the how we feel and how we can extend that acceptance, that gratitude, that generosity to other people, and really confront stigma when we see it and when we feel it. So thank you very much. I'd just like to highlight in Mexico, for those coming for the science conference, we have a pre-meeting specifically around co-infection around HIV and viral hepatitis, and I hope to see many of you there where we can continue this conversation. Thank you.
Thank you. Thank you so much, and coming also from the AIDS community, which truly is inspirational when it comes to activism, I think in a way created global health activism, and so thank you for also a powerful talk. And now we're also going to hear from the Global Fund to Fight AIDS, Tuberculosis, Malaria, Marieke Wiernox. Thank you so much for coming, and the floor is yours.
I think actually the thank you is mine. I've had an amazing afternoon, and I really would express my sincere gratitude to Unite and the Unite team for bringing us all together, and what I consider laying a very solid foundation for the next couple of days in terms of political commitment. But as Lucy said, at this stage of the afternoon, a lot of things have been said already, so I apologize if there's some repetition. I would like to start with recognizing the very important role of parliamentarians, which sometimes we do not acknowledge enough, and the role of parliamentarians at all levels is very critical, and the Global Fund is privileged to work with many of the parliamentarians here in this room, be it as implementers or as a donor. A couple of presenters refer to the Global Fund, so I would like to give a little bit background to what the Global Fund is doing in harm reduction. We are the largest external funder of harm reduction programs by quite a wide margin. In the current cycle, 3-year cycle, the spending is at least 242 million in country programs. If you look back over the last couple of years, we've seen that funding for harm reduction has increased, both in absolute numbers as in terms of countries that have included harm reduction programs. And we see that the funding proposals are better targeted in line with the WHO, UNODC, UNAIDS guidelines. So that's all good news. But the downside is we're scratching the surface of what we're doing, and I think Naomi is coming back to some of the data on the funding. The funding is only a fraction of what is needed, and a lot of the programs in countries are pilot programs, are very small scale, so we desperately need to do much more. On top of the country programs, the Global Fund is also investing quite heavily in advocacy, and we are implementing a really ambitious initiative to identify human rights barriers to access, and then develop comprehensive approaches in tackling those barriers. We invest quite a lot in generating data, and I think Maria Goretti, you have been quoted many times that lack of data in many countries is an impediment to have those discussions with policymakers. And we also invest in capacity building of community organizations, because the community engagement and involvement is absolutely key. But as I said, we are scratching the surface, and we do need to do much more. We need much more money, really much more money, tenfold. And Naomi, again, we'll come back to it. The Global Fund, we're currently in the replenishment year. We kicked it off earlier this year in India. We'll finalize in October, and hopefully achieve our target of at least $14 billion. That's a stretch target. We know we have to work really hard, especially if you consider that 14 billion is our floor. We need at least 14 billion. We'll need all of you to contribute. So if you feel energized to contribute, my colleague Scott is in the audience. He's our focal point. He's in the back. He's our focal point for parliamentarians. So if a parliamentarian you want to support us, speak with Scott. We have Katie in the room. She's leading the Global Fund Advocates Network. She can also give you advice. So please, we need all of you. But as we heard from many presentations, most harm reduction programs are funded by external funding. That makes them very risky. It's very the long-term sustainability is at risk. So we have to have more domestic resources invested in harm reduction programs. And we're working really hard. Domestic resources is a key message in our replenishment campaign. So we work with the countries, obviously, but with technical partners, with foundations, with communities, with civil societies, and not least with parliamentarians, because we need your support to increase domestic funding. In a lot of countries, as we've heard again and again, spend a lot of money on drug control programs. And we yet have to see the first report that demonstrates effectiveness. If countries would only spend a proportion of that money in harm reduction programs, the impact could be really significant. We've mentioned again and again, we need rights-based and person-centered approaches. We need to reduce stigma and discrimination. We know that criminalization is a key driver of HIV. And also there's a lot of evidence, we've heard it today again and again, that decriminalization will lower cost for the criminal justice system, for the penal system, and it will help us to better target people who use, support the people who use drugs. In short, because I see that the lights are flickering, bad policies kill people. And there's overwhelming evidence that harm reduction is effective. The discussion is closed. We should no longer discuss it. We need more funding. We need much more funding. We need bold political leadership. And I'm looking at all the parliamentarians here to lead on this. And I know that you're the tip of the iceberg of the very committed parliamentarians. The rights-based approaches, reduce stigma and discrimination, supportive legal frameworks, and decriminalization. But the good thing for politicians is the results will be visible very soon. I was really struck by both the data from Portugal and China, that basically within 1 year you can see better results in terms of less public impact of bad drug policies. So it should be attractive for political decision makers. I absolutely agree, we need to engage with law enforcement agencies. We also need to engage with media, because media can be a very powerful force to support harm reduction programs. But I've also seen this afternoon in presentations the bad role that media can play in fear-mongering and demonizing people who use drugs. And so we have to work with media. And last, we need all of us working together to make this difference. Thank you.
Thank you. Thank you, Marika. And I think if you didn't tweet it, you should. Marika said it, bad policies kill people. And I think that's a very, very powerful message. And on the funding issue, the World Bank estimates that if we want to complete the Sustainable Development Goals by 2030, in low-income countries alone, it's going to cost $500 billion. If we want to complete them in middle-income countries, it's going to cost $2.5 trillion. It is not going to be done with domestic funding. We need to have a very strong international development policy, and hopefully everyone in this room will certainly continue to fight for this. Now, we have time for a couple burning questions before moving on. Are there any questions in the audience? I know it's getting late, and so if not, please, Your Honorable Member of Parliament from Germany.
Yes, Rudolf Henke from the German Parliament. Christian Democrat, member of the Committee on Health. I mean, Craig McClure has provided us with information where his organization is able to help, and has regretted that it is not in other cases. So I suppose that goes also for the Global Fund. So my question would be, do we have the right concentration upon the fact that the Global Fund has to concentrate on fragile states, on situations where, well, probably middle-income countries could not expect, even if we increase the amount of money which is going to the Global Fund, if we are successful there, if we can reach that, then this must not be understood as the message that middle-income countries would be able to rely upon an institution like the Global Fund, but there must be activity by themselves. As if economy progresses, then there must be a bigger share to be taken into the healthcare system, I believe. And that will again then help to increase economic success. It's a clear relation between economic success and the healthcare situation. And that is the reason why it's economic support when you do health support. But once you have reached something, then I believe that any country is also under an obligation by itself. And we should therefore strive for the strengthening the Global Fund, but not with a message to leaders and countries, rely upon the Global Fund, and then it's done. It isn't.
Okay, thank you. Open for response.
Absolutely agree. Does it work?
Yes, yes.
With some nuances. The Global Fund's focus is on, our priority is for the lowest income countries with the highest disease burden, and that's where it should be. And we have co-financing requirements that increase as countries are richer. So upper middle income country has to provide more co-financing than a low income country. But we have to be, and we want, as I said, that the increased domestic resources based on the ability to pay is a key message in our replenishment effort, because we have to work towards long-term sustainability. The nuance is when it comes to key populations. And we have to take into account that as countries get richer and develop economically, the human rights agenda doesn't always travel with economic development. And there's the most marginalized populations that are the ones that are furthest left behind. And what I was told, I think, I don't know the most recent data, but I presented at the Durban AIDS conference data on HIV prevention, demonstrated 95% of HIV prevention is externally funded for key populations. And that's very unsustainable, that including in middle income and upper middle income countries. So yes, they have to take on a larger share, but we have to make sure that doesn't lead to people being left behind, falling through the cracks, and work with countries to increase funding. And that's a big part of the advocacy that we are supporting, is to work with middle income countries as they develop economically, that they develop policies that reduce stigma and discrimination, that they embrace more positive legal frameworks, that they establish social contracting mechanisms so that the government can contract out services to civil society, to make sure that by the time the Global Fund exits, that we have a reasonable guarantee that programs will be maintained.
Thank you so much. I'm going to ask the speakers to stay on stage, if you don't mind, for the next moment before the closing session. And for this moment, I'm honored to call, well, first of all, a big round of applause for our speakers. I think they deserve it. And I'd like to call on stage Naomi Berkestein, who, of course, as you know, is one of the co-chairs, along with José Queiroz, of Harm Reduction International Conference and the head of Harm Reduction International. And once again, as I said, it's an honor for Unite to be associated with Harm Reduction International. You weren't in the room, but I said when I came from Bucharest, after meeting you, I said to the team at Unite, leave everything you're doing and follow up with Naomi. We need to work with harm reduction. And I think this is the proof that it was worth it. Thank you so much. And we have now a speech on a call to action you want to talk to us about. So please, Naomi, the floor is yours.
The good news is this will take 30 seconds. So the speakers today have made a very strong case for the importance of harm reduction and the evidence base we have. And Marijke spoke so eloquently to the issues, I think I can skip large chunks of my one page of notes. Basically, we at Harm Reduction International emphasize that harm reduction is far broader than HIV prevention, but we also accept that much international funding is currently linked to the HIV response. And as Marijke said, we rely heavily on the Global Fund. Marijke, thank you so much for being here today. Your very presence today and at the conference is an indication of the Global Fund's commitment to harm reduction, so thank you. So I stand up here today to talk because, as Marika said, we're in a replenishment year. And because there's such a heavy reliance on Global Fund funding for harm reduction all around the world, the Global Fund contributes 2/3 of all donor funding for lower middle income countries, or did in 2016. That's a huge reliance on the Global Fund. And so this month, in order to support the Global Fund towards this replenishment, we launched a call to action to galvanize urgent movement towards securing a strong 6th replenishment of the Global Fund in recognition of their incredibly important contribution to addressing the impact of HIV and TB on people who use drugs, but also to express our concern that people who use drugs have been left behind in the fight to end AIDS by 2030. And then also I want to note just in particular, the Global Fund Catalytic Investment Funding provides a vital lifeline for community-led civil society advocacy. Because while now immediately our game plan is the Global Fund, the long-term solution for harm reduction programming is for governments to take that responsibility, for governments to be assigning national budget lines to ensure harm reduction is well funded. The call to action calls on governments, philanthropic donors, the private sector to step up and fully fund the Global Fund. We call on them to make ambitious pledges to ensure not only the $14 billion target is met, but an $18 billion target is reached. We call on governments to put people before politics. And we call on the Global Fund to safeguard catalytic investment funds because of the importance of advocacy in ensuring we can transition from our current situation of reliance on the Global Fund to a future scenario where governments are committed to funding harm reduction as a response. And I urge you all to sign our call to action at hri.global. But today, this afternoon, we have a very exciting moment because with Ricardo's leadership at Unite, we're going to have members of Parliament sign on to the call to action. And I'm very pleased to invite Ricardo up, indicating his commitment to funding the harm reduction response and ensuring people who use drugs are not left behind in our efforts to address HIV, Hep C and TB. And I welcome other members of Parliament in the audience and on the stage here to gather for a photo as we sign the pledge. Thank you so much.
So we are moving very quickly to our closing session. Before passing the floor to our speaker for the closing session, I would just like to call for your attention and also ask, I would like to thank each and every person involved in the organization from here, from Santa Casa da Misericórdia of Porto, from Unite, the whole team led by Christina, without whom we wouldn't be here today, and have done an extraordinary job getting this together. And to everyone else involved, from the audiovisual team, from our hostesses, everyone played a pivotal role in making sure that this was a successful conference. And so I am a bit emotional, to be honest, after what we just did. And I have to thank you all very much for making this a reality. And this wouldn't be possible without your hard work. And so a very strong round of applause for all of them, please. And at the top of a cake, we have to put a cherry. And at least that's how we say it in Portuguese. And we couldn't end this conference with a better and most inspiring speaker than Professor Michel Kazatchkine. Professor Kazatchkine, as you all know, I don't have to share your whole CV. It is very long and very well known. But you are a member of the Global Commission on Drug Policy, and of course in that condition you are coming here today, having known your role in France as a true leader, advocate, physician, policymaker, a true leader in the field, and your work in the Global Fund, and also as a UN Special Envoy, and also as an advisor to UNAIDS in Central Asia and Eastern Europe. And truly a very good friend, but most importantly, a very strong supporter of Unite, but most importantly, of pushing for global health for all and not leaving anyone behind. We are truly inspired every time we meet, every time we get to work with you, and we are truly honored that you have accepted to do this closing speech. Thank you very much.
Well, thank you very much, Ricardo. I'd like to join everyone in thanking you. This has been a very inspiring, informative, remarkable day. I really like the openness of the discussions, so thank you very much, Unite. Thank you for restating your call on ending HIV, hepatitis, and TB among people who use drugs. Thank you, Naomi, also for initiating, I can't see her, for initiating that call of support to the Global Fund. I think I'm well placed to understand how important that replenishment will be for harm reduction. So, honorable members of parliaments, dear colleagues and dear friends, I'm speaking here on behalf of the Global Commission on Drug Policy, and you can see on this slide the current list of the 24 commissioners. Some of you may be familiar with some of our reports. But let me focus on today's subject, which is HIV, hepatitis, and TB among people who use drugs. And let me start by saying that despite some of the remarkable progress and remarkable policy moves that we have been witnessing, and some of which we've been hearing today, particularly here in Portugal, but also in a number of other countries in Western Europe or Canada. But if we look at the situation globally, we're very far still from where we need to be to eliminate hepatitis, HIV, and TB among people who use drugs. And we should recognize that in many countries of the world, drug policies have not contributed to achieve the health and welfare of mankind that are the original goal of the United Convention of 1961, as stated in the preamble. The current situation is that 1 of 8 persons, people who inject drugs, is living with HIV. And as you heard, that the incidence of HIV is still on the rise among people who use drugs. The fact is that more than half of the people who inject drugs across the world, that is over 8 million people, are living with hepatitis C. 1.3 million people who inject drugs are co-infected with HIV and hepatitis C, and this is 1/2 of the global burden of the HIV-HCV co-infection. And the fact is that people who inject drugs are at a significantly higher risk of tuberculosis and have a higher prevalence of latent TB infections than the general population. And this is now recognized to be clearly linked to the high rate of incarceration of people who use drugs. And in Eastern Europe, if you're a person using drugs and you acquire TB, that means MDR TB, multi-drug resistant TB, in most of the cases. Overall, coverage with HIV and with hepatitis treatment remains far too low among people who inject drugs, and so is access to harm reduction. Currently, less than 1% of people who inject drugs live in a country with high coverage, as defined on the slide, with high coverage of needle syringe or opioid maintenance therapy programs. So as many of you have said this afternoon, it's really beyond time to stop talking about drugs in moral or criminal terms. We're now with more than 30 years of evidence-based analysis in support of harm reduction and public health approaches. So in the next few minutes, what I'd like to do is actually recall 3 of the pathways that the Global Commission is proposing for reforming drug policies to ensure that these policies support and encourage prevention and treatment based on evidence of what works. The first is that drug policies should always prioritize the safeguarding of people's health and safety. This means investing in community protection, prevention, harm reduction and treatment as cornerstones of drug policy. It means a substantial scale-up of harm reduction that includes all proven harm reduction interventions today, beyond needle syringe programs and opioid maintenance treatment programs, including access to street drug testing, to safe consumption sites, to heroin-assisted treatment. Harm reduction that is comprehensive, that is of high quality, evidence-based, effective and affordable, and also harm reduction that research and science needs to help us adapt to the new dynamics and changing realities of drug markets on the streets. This means access, as discussed by several of you this afternoon, access to integrated, community-based services for people who inject drugs that would include harm reduction, HIV, HCV, and TB testing and treatment without restrictions and without stigma. This also means, and that's been discussed again today, expanding access to prevention and treatment for incarcerated people and ensuring continuity of care upon release from prison. And it calls, and I think Miriam, you had alluded to that, a fundamental reorientation not only of policies, but also of resources from failing punitive enforcement, law enforcement, to proven health and social interventions. I mean, Naomi, there's no stronger supporter than myself to your call. But what I'm saying here is that we also have a way to fund these social services, and that is, again, if the political will is there, to find them in absolutely wasteful current investments in ineffective law enforcement on the streets. The second pathway is decriminalizing. And actually, in our minds of the Commission, it's not just decriminalizing, it's ending all penalties, both criminal and civil, for drug possession for personal use. It's been said many times this afternoon, laws that criminalize people who use drugs are ineffective and harmful. Far from their stated intention of protecting public safety, they've actually been severely undermining public safety. Criminalization has led to an unprecedented wave of over-incarceration that has had profound effect, negative impact on the health of people and communities, and on public health. Beyond decriminalization for personal use, we also believe that states, governments, should aim at diverting away from the criminal justice system, all low-level, non-violent actors in the drug trade, such as those engaging in social supply, drug couriers, user dealers, cultivators of illicit crops, many of whom engage in these activities due to lack of economic opportunity. But as also alluded this afternoon, decriminalization is needed, but it's not the end of it. In many countries, decriminalization is on the paper. Many countries, it's on the paper, but it's not in the reality. It's not translated on the streets. And its potentially positive outcomes for people who use drugs and for society are rarely fully realized. This is, for example, because of very narrow thresholds that the law would define between what would be called use and what would be called traffic. It is also because, despite decriminalization is there on paper, harsh policing on the streets and harassment of people who use drugs in communities persist. And it's also because of the reliance on penalizing people with fines that are often so high, the fines, that people cannot pay them, and which ultimately will lead the offender back to the criminal justice system and incarceration. And I must say here, as a citizen of France, that I'm really frustrated with one of our recent attempts at decriminalizing, which in fact installs such a system of heavy fines. So decriminalization, in our minds as the Commission, does not go far enough in the changes and in the reforms in drug policy that we need. So the third pathway requires revisiting the current fundamentals, the current principles of international drug control, and aiming at actually ending prohibition, ending the prohibition paradigm, and moving towards legal regulation of currently illicit substances. And this is because the demand for drug exists and it will remain. And if it is not met through legal means, it will be supplied by an illegal market with all of its negative consequences that we heard about. The circulation of adulterated drug products, as we see in the US now and Canada with fentanyl. Continuing epidemics of HIV, hepatitis, and TB. For people who use drugs, life lived under threat of arrest and incarceration, preventing people from seeking treatment, care, and support. And the perpetuation of an international criminal market that, as we all know, fuels corruption, violence, and insecurity. Accepting that very basic reality, I think, is part of what should be responsible governance. Dealing with the world as it is in contrast with morally or ideologically driven, utterly impractical and ultimately counterproductive attempts to create a so-called drug-free world. So, as I've said, decriminalization alone is not sufficient. Just as for any substance that is potentially dangerous, just as for any product the consumption of which is accompanied by health risks, governments and the international community need to move towards legal regulation to ensure quality, to protect public health, and promote safe and responsible use. Ending prohibition and moving towards legal regulation of all drugs, starting with low-potency drugs, as it is started in a number of places around the world with cannabis, is the critical next step in drug policy reform if the many individual and social harms of prohibition and of illegal drug markets are to be reduced. It is time that we transform the international conversation away from prohibition to an approach that emphasizes safety, rights, health, equity, and ultimately development. And finally, let me come back to something that we've heard throughout the afternoon, which is the importance of social determinants and human rights. As policymakers committed to public health, we need to do better in recognizing the implications that the determinants of health and human rights have for health governance. I cannot think of any effective approach to governance for health that would not aggressively address the inequities, the human rights determinants, the socio-economic determinants, and the security determinants of health. And of course, rational drug policies require close attention to each of these areas. It is time for governments to move from their focus on governing behaviors, sexuality, reproduction, drugs, what Michel Foucault called biopower or biopolitics, yes, to fully reflecting on how public policies ultimately impact on human lives. A primary objective of good governance for health today must be to close the gap between the rhetoric and the reality, between constitutions that proclaim all human lives to be equal, of equal value, and practices and policies that degrade and devalue drug users in far too many countries. So we must continually affirm the place of human rights at the forefront of governance for health. The Universal Declaration of Human Rights and other charters since 1948 have enshrined some fundamental rights: the right to health and decent care, the right to freedom from discrimination, the right to equality before the law, the right to privacy, the right to work, the right to education, the right to benefit from the advances of science. And as some of you may have heard me say before, these rights are and will remain universal, and they're also the rights of people who use drugs. So we will not win the fight against HIV, hepatitis, and TB without also prioritizing our fight again for these rights in all of our policies. Thank you.
So as I start the meeting, big thank to, we'd like to thank the partners and supporters that made this meeting available, and a fantastic event, as we all agree. And I want also to thank to my team that really made this all together made this meeting possible. So if my team could come here to the stage, I would like to have all of here, if they are there. But also to give you, in the time they will move here, the information that to the ones that confirmed the dinner, will follow now for the dinner. There's a bus outside. We'll join here in the door near where we had the registration, and we'll go for the dinner on the when we end this event. Okay. Again, it was a tough day with so many presentations, but I also want to thank you for keeping on the time. So thank you for that. Please, Tim.